My name is Dr. Matthew Fien. I'm a periodontist practicing in South Florida. I wanted to take a minute and talk about the OsteoGen Plug. The OsteoGen Plug from Implodent is a material that I've been using more and more in my practice because I've learned over the last 15 years that in many cases, we really want to try to be as minimally invasive as possible. This material allows me to get away from using particulate bone graft and collagen membranes. It allows me to get away from trying to obtain primary closure, following these types of treatments. And it's provided me with a predictable protocol that I can use for my patients when we're trying to preserve the alveolar ridge dimensions. It gets me away from having to get primary closure because this material can be left exposed. And really the handling of this material is so simple that it's something that's really sped up these procedures for me and has become really a practice builder in terms of patients' compliance and patients accepting treatment. And so this material is composed of type 1 collagen interspersed with calcium phosphate. As you can see, I'll typically take this material to the site in its dry state. If we have long roots or multiple roots, so for a molar, for instance, we can even cut this material so that it will actually get placed into all those little nooks and crannies at the bottom of the socket. I'll typically use this bone condenser from Implodent that has this 3mm tip that I'll typically use first, and then I'll move to the larger tip, and really the goal is just to compress this material right to the level of the soft tissue. Now, one of the benefits of this material is that it is very hydrophilic, and so once it gets wet with blood, you can really see how that blood will infiltrate through this material, and that's really what's going to drive our new bone formation during the course of healing. The other major benefit of this material is that we can leave it exposed, and so by using a cross mattress or figure 8 suture, usually with a either non-resorbable suture or a long-lasting resorbable suture like you see here, we're basically just creating a brace to prevent that material from being removed from that socket during the early periods of healing. Now, really, again, the benefit is this hydrophilicity. So once I can place this material into that socket gently, you can see when there's blood in this simulated socket, the material will get completely saturated with the blood, and that's really what we want. So the key to any of these procedures is to make sure that we're completely degranulating the site, removing all remnants of soft tissue, and then making sure that we have good bleeding of the site when we're placing this material into the socket. And to be patient, allow a couple of seconds for the blood to infiltrate through the material, and then we'll just gently compress, again, usually using the smaller end of my bone packer, which is about a 3mm tip, and then we'll use the larger socket packer to make sure that we have even compression of that material right to the level of the soft tissue, and then using a resorbable suture that lasts at least 3 to 4 weeks, or a non-resorbable suture, we can then stabilize this material at the site so we don't lose this material during the early periods of healing. And as you can see, I'm using this material for a wide variety of cases, but especially when I have a nice healthy bleeding socket where I'm not raising flaps to extract teeth. Again, very critical to make sure that we've degranulated the site completely. We're going to allow the bleeding to occur and to infiltrate into this material. It only takes a couple of seconds, but very important. We don't want to over compress the material. We want to allow the architecture of the material to really drive the bone healing. And so as you can see, once the material's wet with blood, we'll lightly compress it to the level of the soft tissue, place a non-resorbable suture or a long-lasting resorbable suture, with the key point here to not try to obtain primary closure, which is better for us. We don't have to raise flaps to do that, and it's much better for our patients because we don't have to create the morbidity associated with getting primary closure following these types of procedures. As you can see, we have beautiful healing at 3 to 4 months post-treatment, and that allows me to re-enter these sites at that time and have excellent bone quality to be able to place our implants in that prosthetically driven position in healthy bone, getting great primary stability. And so I think this material has really changed the way that I've practiced over the last couple of years, and I hope that you found this helpful. Please let me know what your experience is like. Thank you.